Welcome to Prescription Writing Basics. In this recording, you will be introduced to the fundamentals of writing prescriptions. We will analyze the components of a prescription as well as discuss some common errors. Additionally, we will review the grading rubric associated with each prescription you will submit in this course. Many students often wonder why handwritten prescriptions are a required component of this course. The argument they give is that no one actually uses a pen to write a prescription anymore. It's all done electronically, and all the drugs and doses are already built into the electronic health system. Well, this is true, but only partially so. I'll share with you the staggering number of prescription errors that occur in this day and age and guarantee that not all of these errors are handwritten prescriptions. Many are electronically generated. In the experience of your PA program faculty, understanding the components of a prescription will help you avoid such errors when you are in practice. And one of the most effective ways to make sure you truly understand the components without relying on a computer is to require you to handwrite prescriptions in this course. Almost 3/4 of acute care encounters involve at least one written prescription. That's a lot. It equates to over 4 billion prescriptions written each year, and what is extremely sobering is that 1/3 of those 4 billion prescriptions contain some sort of error. This is not to say that all of these errors are catastrophic, but they are present. And this comes down to the fact that we have more and more drugs that are coming on the market. In fact, the FDA approves 1 to 2 new drugs every week, so that's 100 new drugs or so every year. There are also a lot of look-alike and sound-alike drug names. Additionally, the units of measurement can be a real big issue. With all of that having been said, it is important to note that even with electronic medical records, it is imperative to understand the correct components of a prescription so as to avoid these errors. Blindly trusting the EMR system that you use in clinical practice will definitely get you into trouble, as not all of the information built into the system is correct. You still need to use your own brain and ensure that what is submitted on the computer is correct. I've made mention several times already about the required components of a prescription, and here they are, listed out for you item by item. Whether it is a controlled or non-controlled drug, which we will define shortly, you have to have all of these components. Let's go through them component by component. First is the date of issuance. This is the day that you are writing the prescription. You are not allowed to predate the prescription, nor should you backdate it. Simply write the month, day, and year that you are writing the prescription for the patient. It can be in military format, which is day, then month, then year, or civilian convention, which is month, then day, then year. Either one. Next is the patient information. This includes the patient's formal name, not his or her nickname, and their address. It should also include age or date of birth. Most prescription pads have a line that states age. For this class and for your clinical practice, I encourage you to use the patient's date of birth in that section instead of the actual age in years. It is more specific than the age and can be used as an additional identifier. So, in the age section of the prescription, insert the patient's date of birth. As for the address, the nice part about EMR is that it is pre-filled for you with specific patient identifiers such as their address. However, in this course, you will be provided with the patient's address for each prescription, and you are expected to fill that information in on the handwritten prescription. This ensures that you are treating the correct patient, and it helps the pharmacist ensure that it is the correct patient who was intended to have the particular medication. And, as previously mentioned, note that you must include the patient's formal name, not a nickname or initials. The last thing that should be included in the top part of the prescription, if it's a pediatric patient or an adult patient with a weight-based dosing schedule, you need to put their weight, which is conventionally in kilograms. So as a recap, at the very top of a prescription, which is called the superscription, you should have the patient's formal name. In this case, she might be called Fran, but we would still write Frances since that is her formal name. In addition to the first and last name, you should also provide the patient's birth date, the date the prescription is written, the patient's address, and weight in kilograms, especially if it's a pediatric patient, which this patient is. Providing the weight along with the dosage formula used allows another healthcare professional, such as a pharmacist, to double-check the prescribed dose. Now on to the body of the prescription, which is called the inscription. This section contains the name and amount or strength of the drug to be dispensed. It is considered best practice to write out the name of the drug in its entirety. Now, some drugs like hydrochlorothiazide are commonly abbreviated to HCTZ, but to avoid any ambiguity or confusion, the entire name of the medication should be written out. Either the trade name or the generic name of the medication can be used. If you use trade names, you need to be careful in transferring unnecessary cost onto the patient. For example, if you write a trade name for a medication that also has a generic formulation, the pharmacist might think you are requiring the trade medication, not the generic. There are slight differences in trade versus generic medications, and there can also be some major cost differences between the two, depending on the patient's medication coverage. So at the bottom of most prescriptions, you can indicate if substitutions are permitted, or if the pharmacist should dispense as written, meaning they should give the patient exactly what you wrote. For purposes of this course, I am not going to be holding you accountable for substitutions versus dispense as written or no substitution designations. But when you are writing prescriptions for real patients and are affecting their wallet, it is something you should definitely be mindful of. As for the strength of the drug, please note that strength is not the same as the total amount to be taken by the patient over the course of the prescription. The strength of a medication is that number, usually in milligrams or micrograms, etc., that is how the medication is manufactured. For example, glucophage, which is metformin, can come in 100 milligram, 500 milligram, 850 milligram, or 1000 milligram tablets. You have to indicate which strength you want the pharmacist to give the patient. When you are looking up medications and prescribing references, you can often find the available strengths in a section marked How. The second line of the body of the prescription is called the subscription. This is your instructions to the pharmacist, including the number and type of units to dispense. The amount dispensed should be the amount needed to complete a course of treatment, so that you may have to perform a little math to get to that number. You also need to clearly state if you want tablets, capsules, a suspension, etc. In the case of this sample prescription, the inscription, or second line of the body of the prescription, instructs the pharmacist to dispense, that's what the abbreviation DISP means, to dispense a total of 20 tablets. How do we determine that 20 tablets are needed? Well, we can look up the prescribing information for this medication. You will find that there are various resources to do this, including MPR, Epocrates, the manufacturer's website, and FDA documents, to name just a few. You will be exposed to a multitude of resources during this course so that you develop the skills to extract the information you need from each document so that you can write a prescription. This is a copy of the FDA datasheet on Cipro. It's 91 pages long, and embedded in it is the dosing schedule and how the medication is supplied. If we are treating our patient for a complicated UTI, we see the recommended dose and frequency is 500 milligrams every 12 hours for 7 to 14 days. We can also see that the pills are in tablet form, not capsules, and they are available in 250 milligram, 500 milligram, and 750 milligram strength. So back to our prescription, if we know we need 10 days worth of treatment and each day requires 2 pills, one every 12 hours, we need a total of 20 pills. 10 times 2 equals 20. And since these come in tablets, we need to state tabs or tablets. Note that some medications come in both tablets or capsules, so this is why we need to make this designation. Capsules can't be crushed or split, while tablets often can. Also, there can be a difference in price between tablets and capsules. The blood pressure medication diltiazem ER, which is Cardizem, comes in a capsule and tablet at all doses, and the capsule is much cheaper than the tablet. There is no benefit of one over the other. But there are rare examples where the tablet and capsule are slightly different. Xanaflex is a muscle relaxant, and the tablet form is much more expensive than capsules. The two forms of this medication are bioequivalent under fasting conditions when taken on an empty stomach, but not under non-fasting conditions when taken with food. I don't expect you to know all these details at this point in your training, but I want you to understand why specific designations such as tabs versus capsules are important on a prescription. Sometimes instead of seeing DISP written, you just see the number or hashtag symbol and then the amount, as in this case. Note that the amount is written out, 20 instead of 20. This is a good habit to employ since this prevents patient tampering with prescriptions of commonly abused substances. The third line of the prescription is known as the Cigna. We often see SIG written, and that is short for Cigna. These are the patient instructions and must include the route, that's oral, rectal, topical, in the eye, etc., as well as how frequently to take the medication, once daily, twice daily, every 6 hours, etc., and the duration of the therapy if it is not a long-term medication. An important point here is that if it's a PRN or as-needed medication, you need to state when it should be used. For example, take 1 pill by mouth every 6 hours, PRN fever, or take 2 pills by mouth every 8 hours as needed for back pain. I do not want to see you write take 1 pill by mouth every 6 hours as needed. You must be specific as to why the patient should take the medication. In this example, you see the Cigna, which states, take 1 tab by mouth twice daily for 10 days. So we see the amount, the route, the frequency, and the duration, since this is clearly a short-term antibiotic course. It is from the SIG that you can figure out the number you want the pharmacist to dispense. So sometimes you will see people flip the second and third lines of a prescription. Like this. Notice the SIG is now the second line. This is perfectly okay to do. How you order the second and third line can be based on your personal. Let's finish up with the content. You see that indication is in italics because it is not something that is absolutely required on prescriptions, but it is highly recommended. This helps patients keep track of why they are taking a medication and allows for the pharmacist to understand dosing. We have already discussed the rule in this class is that when writing a PRN medication, you must include the indication or symptom for which the patient should take the as-needed medication. But you can also include the condition for non-PRN medications, such as UTI in the case of the Cipro prescription we saw on the last slide. The refill amount is often found at the bottom left-hand side of the prescription. This is how many times a patient can obtain a refill on the same med prior to requiring a new prescription. In most cases, the maximum allowable time one can receive refills is up to 1 year. Refills for controlled medications are restricted, as we will discuss next. You are advised to write none instead of 0 for no refills so that a patient cannot add a 1 in front of the 0 to make 10 refills or some other sort of manipulation. Restricting refills can ensure that a patient complies with follow-up appointment. The practitioner name, title, address, and phone number are usually pre-printed at the top of the prescription when you are in clinical practice. However, if you are new to a practice or your name is not listed on the prescription, what you would do is sign on the signature line at the bottom right and then underneath print your name as well as your state license number. Remember to include your title with your signature. That will be PA-C once you have passed your boards. For purposes of this class, you will sign your name followed by PA-S for student. But please note that you cannot sign prescriptions while you are out on clinical rotations. A licensed MD, DO, PA, or NP must actually sign a prescription to make it a legal document for an actual patient. We are just getting in practice with the process with this course. Once again, here is the sample prescription in the recommended format. Let's talk briefly about controlled substances. You can see some examples on the right-hand side of the chart. These are medications that the DEA tracks the prescribing and dispensing of very closely. They monitor who prescribes them, how much is prescribed, and which patient is getting them. Prescribing these medications requires a separate license, and that particular license designates which of the 5 schedules of a controlled medication you can prescribe. The lower the schedule number, the higher the abuse potential. So Schedule II drugs are much more addictive and more commonly abused than Schedule V medications. According to the DEA, Schedule I drugs have, quote, no currently accepted medical use in the United States, a lack of accepted safety for use under medical supervision, and or a high potential for abuse, end quote. Some prescribers can only prescribe Schedule V controlled substances, or maybe Schedules IV and V. Without a DEA license, you cannot prescribe any controlled substances. In Virginia, as a PA with a DEA license number, I can prescribe Schedules II through V. This means that I have a Virginia state license to practice as a PA in the state of Virginia, and then I have an additional DEA license that allows me to prescribe controlled substances, since I am in a surgical subspecialty and prescribe opioid pain medications for those post-op patients. That DEA license requires submission of an application and costs $731 for a 3-year license. In terms of a prescription for a controlled substance, there are some important differences from non-controlled substances. There are restrictions on how the prescription is submitted, how much of the medication can be dispensed, and number of refills allowed. The DEA website provides access to a practitioner's manual that outlines these details. In that manual, it stipulates that a prescription for controlled substances in Schedules 3, 4, and 5 issued by a practitioner may be communicated either orally via the phone, in writing, or electronically to the pharmacist, and may be refilled if so authorized on the prescription or by call-in. However, the prescription may only be refilled up to 5 times within 6 months after the date on which the prescription was issued. After 5 refills or after 6 months, whichever occurs first, a new prescription is required. Schedule II controlled substances, such as oxycodone and morphine, require a written prescription which must be signed by the practitioner. There is no federal time limit within which a Schedule II prescription must be filled after being signed by the practitioner. While some states and many insurance carriers limit the quantity of controlled substance dispensed to a 30-day supply, there are no specific federal limits to quantities of drugs dispensed via a prescription. For Schedule II controlled substances, an oral order is only permitted in an emergency situation. The refilling of a prescription for a controlled substance listed in Schedule II is prohibited. For state-based regulations on controlled substances, you should go to the Board of Medicine website for the state in which you are licensed. On this slide, you will see some new regulations imposed by the state of Virginia regarding opioids. These updates are emailed and posted to the State of Virginia Board of Medicine website. Failure to abide by these regulations may result in fines and/or disciplinary action. You simply must be an informed provider when you prescribe controlled substances. For purposes of our course, Problem-Based Clinical Reasoning, we will assume that you have a DEA number, thereby allowing you to write for controlled medications for our virtual patients. You may use your student ID number as your DEA number and should include that number underneath your signature for any prescriptions we write for controlled substances in this class. So once again, it is the exact same components on a controlled prescription as non-controlled prescription. Just pay special attention to writing out the amount dispensed so that it cannot be altered by the patient, and ensuring that you include your personal DEA number. Here we have another sample prescription from a textbook on pharmacology. As we have discussed, you see the patient's name and address. Instead of age, you should get in the habit of identifying the patient's date of birth. That's much more specific, and I'll be looking for the date of birth instead of or in addition to the patient's actual age. The other modification I would make to this prescription is moving the amount dispensed so it's on its own separate line. That way there will be 3 lines, one with the drug name and dose, one with the amount dispensed, and one with the patient instructions including amount to take, route, and frequency/duration. As mentioned previously, it is a good habit to also include indication for use, as the comments on the bottom of this slide explain. Since Dr. Hansen's name is at the top of the prescription, he or she does not need to print his or her name at the bottom of the prescription. But if I was writing this prescription, I would need to sign it and print my name immediately below my signature so the pharmacist could find me in the National Provider Database. A DEA number is not necessary on this prescription because losartan is not a controlled substance. This is the rubric for prescription grading that will be used for this course. There is a copy of this rubric in your syllabus, and each prescription you submit will be evaluated based on these criteria. All prescriptions are hand graded based on these 10 criteria. Let's see how this sample prescription would score in this class. The patient name and address are present, but the date of birth is not. You will only receive partial credit if you do not include the date of birth. As for format, there are essentially 2 lines of information, not 3. Credit would not be given for this. As mentioned previously, move the dispense number 30 to a new line to receive full credit. The drug name is there, as is the dose, which is 50 milligrams. Even though the amount dispensed is not in our required format, the information itself is there, so you would receive credit for having the actual component. And amount dispensed includes appropriate refills, which are indicated appropriately here as well. The amount to take is 1 tablet, the route is by mouth, the frequency is daily in the morning. The provider signed this prescription and his or her name is pre-printed at the top. On your prescription pads for this class, your name is not at the top, so you have to print your name under your signature at the bottom of the prescription in order to receive credit. So overall, if this was your submitted prescription, you would receive 1.7 out of 2 points in problem-based clinical reasoning. Remember that prescriptions should be written in blue or black ink, not pencil or hot pink pen or some other color. At this point, most students wonder why in the world we are so picky about prescriptions. Well, I'll tell you. This is why. Here we see an excerpt from an online prescribing reference such as Epocrates or EMPR for the antibiotic ciprofloxacin. You can see that in terms of dosage forms and strength on the left, there are IV options, oral suspensions, which are liquids, tablets in various strengths, as well as a couple of extended release formulations. In short, there are a lot of options. The pharmacist has no idea who this patient is and why they are receiving treatment. Cipro is used to treat anything from sinusitis to infectious diarrhea and pneumonia and UTIs, as you can see on the right. So with all the various forms and strengths and indications for Cipro, it is necessary for you to be very specific in your instructions to the pharmacist and the patient so there are no assumptions that have to be made. Assumptions are what hurt patients. If you include each of the 10 components we discussed, no assumptions will have to be made on the part of the pharmacist or the patient. The common errors that we see are illegibility, which of course applies to handwritten prescriptions, or omissions, leaving something off. For controlled substances, providers can be guilty of prescribing more than is allowed by state law. The state of Virginia states you should never exceed 5 to 7 days' worth for a patient prescribed an acute pain medication. You also need to be sure that you include your DEA number and avoid writing a controlled or scheduled 2 through 5 medication if you do not hold an active DEA license for doing so. Unclear quantity prescribed is an amount dispensed that does not match the instructions in terms of the math. For example, if something is a daily med that you specify should be taken for 10 days, that's 10 pills. But if you instead write dispense number 14, the pharmacist and patient don't know if you intended them to take the pill daily for 14 days or if you really meant 10 days and wrote the wrong amount to dispense. The result? The pharmacy will call you for clarification. Be intentional as well about indicating route in your directions to the patient. What seems common sense to you is often not common sense to your patients. If you are treating a child for an ear infection and give a liquid prescription without instructions about where to put it, a parent might assume they are to insert it in the ear. After all, that's where the problem was, right? So clearly state 1 teaspoon or 5 mL by mouth twice daily times 7 days for right ear infection. Be specific. Lastly, leading and trailing zeros take us into the realm of approved and unapproved abbreviations from JCAHO. This is a very important slide, but if in doubt, do not abbreviate. Write it out. This is called the Do Not Use list, which applies not only to prescriptions but also to chart documentation as well, including progress notes and orders. These abbreviations boil down to causes of potential errors, and there is a description beside each one indicating why that particular abbreviation is problematic. For example, the abbreviation IU for international units can be mistaken for IV, or perhaps the number 10. The particular ones that most directly relate to your prescriptions are QD and QOD because they can be mistaken for each other. So you cannot use those abbreviations and must write out daily or every other day instead. The other one I want to point out is the one second from the bottom on the left-hand table, which mentions trailing zeros and lack of leading zeros. If you are writing for 10 milligrams, you need to write 10 milligrams, not 10.0, because that decimal point can be lost and it looks like 100 milligrams. The same is true if you are writing for a half a milligram. Writing 0.5 can be mistaken for 5 milligrams, so you have to include a leading zero before the decimal, making it 0.5 milligrams. The examples that follow illustrate the importance of legibility and illustrate how information can be misconstrued if you are not diligent in your prescription writing. For just a second, look at this example and consider if you think the provider is writing for Buspar, an anti-anxiety agent, or Prozac, an SSRI antidepressant. As it turns out, the pharmacist who didn't know that the patient has depression dispensed Buspar 10 milligrams instead of Prozac 10 milligrams. Two completely different classes of medications that do two very different things, but you can see how this mistake could be. How about this one? Is it Vantin, a cephalosporin, or Vasitec, an ACE inhibitor? Well, it should be Vasitec 20 milligrams because our patient is hypertensive, but instead he or she received Vantin 200 milligrams. The takeaway point? Be diligent in writing your prescriptions. Many people thought the solution to this illegibility and tendency to misinterpret written prescriptions was the EMR. That's the electronic medical record. With this, it would be so much more clear, right? The patient's info is pre-populated, the prescriber's info is all loaded into the system already. You just click on the pull-down menus and pick the right dose and frequency. Error-proof, right? Well, unfortunately, that's not the case. There can be incorrect product dose or frequency that shows up in the drop-down menus, especially with new drugs that have recently been added to the system or medications that tend not to be used as frequently. Many clinicians also make the mistake of assuming the default dose for the EMR, the one that it defaults to, is the correct dose for what their particular patient needs. As we saw with the prescribing reference for Cipro earlier in this recording, there are multiple doses and the duration of treatment varies based on the condition you are treating, so it is not a one-size-fits-all situation. You need to know where to find the appropriate dosing for the exact condition that you are treating and then make sure that the prescription reflects that. Also, factoring in specific patient context is important. For example, if your patient has decreased GFR, you will likely need to prescribe a lower dose of the medication. Lastly, and perhaps most importantly, we as a technologically advanced society have fallen victim to alert fatigue. We are so used to seeing notifications, pop-ups, messages, and updates that we habitually dismiss them without really reading what they are saying. Hitting the ignore button while composing a prescription can be dangerous for the patient if one of those warnings was about drug interactions or drug allergies. When we write out a prescription, we tend to use that type 2, more analytical thinking as we go through each step. So remember that process and be diligent about knowing and checking the components of a prescription even when you are writing them electronically. Remember that EMR is better in terms of avoiding some of the illegibility issues, but it is not truly error-free and without its own set of problems. To finish up, it's important to understand the world of pediatric prescriptions and other weight-based prescriptions because they involve a lot more thought and math than most of our other prescriptions. We are going to focus on suspensions, which are liquid medications. When you have a liquid, you are given the concentration, which is the amount of medication in milligrams per 5 ml. Remember that 5 mLs equals 1 teaspoon. So it's saying that you can get amoxicillin in liquid form with a concentration of 125 milligrams per 5 mLs or teaspoon, or you can get it in 250 milligrams per teaspoon. Why the difference in the amount? Well, it's based on how big the patient is, which correlates to how much they need and how fast their body will metabolize the drug. There are also capsules and chewable tablets, but for little ones, we tend to use the liquid suspension. When you get ready to write a prescription for a liquid, you need to know a few things. The patient's weight is the first thing. Usually this is something we obtain in pounds, but it needs to be converted to kilograms. Number 2, we need to know how much you will be giving them over the course of a day. That's the daily dosing requirement for a particular condition. In the case of amoxicillin, it's 50 to 90 milligrams per kilogram per day. Thirdly, we need to know how frequently they need to be taking the medication in a day. In other words, is it a daily dose, or is it something that they take twice a day or 3 times a day? And lastly, the concentration that the medication comes in needs to be. Let's walk through the steps of formulating a prescription for a child needing liquid cephalexin for the condition that you see illustrated in the picture. Any ideas what that is? Those of you that guessed impetigo are correct. It's a bacterial skin infection, and because it involves the patient's mouth and nose, we probably want to use a systemic antibiotic as opposed to something topical. A cephalosporin has good coverage against gram-positive organisms which live on the skin. So we look at the prescribing reference and see that cephalexin can be used to treat impetigo. And it gives us the info we need to know. A dose of 25 to 50 milligrams per kilogram per day. That's the daily dose, but it is not to exceed 1,000 milligrams per day. This means that if we do our calculations and it adds up to 1,200 milligrams, we drop it down to 1,000 milligrams. It is given in 3 to 4 divided doses for 7 days, so lots of math for us to do. These are the 4 big steps for weight-based medications, and this applies to either peds or adults who require a weight-based prescription. Step 1 is to convert the patient's weight in pounds to kilograms. Next, calculate the dose in milligrams. That's our daily dose. Then divide the daily dose by the frequency, such as 2 if you want the patient to take the medication twice daily. And lastly, you need to convert the milligram dose to milliliters since we are working with a liquid medication and have to measure it out. Let's try it for our 44-pound baby with impetigo. Taking you back to some middle school math, you must understand the concept of cross-cancellation. You know that there are 2.2 pounds in 1 kilogram, and you should all know that to convert pounds to kilograms, you divide by 2.2. But if you look at the cross-cancellation equation you see here, it becomes apparent why the pounds become kilograms. The pounds cancel out, and you are left with kilograms. Now we can calculate the dose in milligrams. It says 25 to 50 milligrams per kilogram per day. So how do you decide what number you should select within that range? One option is to pick a number in the middle somewhere, and I typically pick one that is an even number and therefore easier to work with. But in this case, I picked 40 because it's right between 25 and 50. You could have picked 37.5 or 38 because those are right in the middle, but 40 is close enough and it's easier for me to do the math with. So 40 milligrams per kilogram would be 40 multiplied by 20, which is our impetigo patient's weight in kilograms, which equals 800 milligrams per day. That's our daily dose. Alternatively, you could run the numbers with each end of the dosing range. So you would calculate what 25 milligrams per kilogram would be, which is 500 milligrams per day, and then calculate 50 milligrams per kilogram, which is 1,000 milligrams per day. Then choose an amount in the middle. 750 milligrams is right in the middle of those two numbers, so you could use that or round up or down just slightly. So whichever way you decide to do it, we now know the daily dose in kilograms. But remember that our prescribing reference seen here said we have to have our patient take this 3 to 4 times per day. This means we divide the daily dose by 3 or 4. Why did I pick 3? Well, because I have kids and I have treated kids, and it's easier on the parents and the patient the fewer times per day they have to take a medication. Dividing 750 milligrams by 3 is 250 milligrams per dose. You could have also used 800 milligrams divided by 3, and that's 267 milligrams per dose, which no one is going to measure out, so you would likely round to 250 milligrams anyway. Next and last, we have to convert our specific dose from milligrams to milliliters using the concentration of the medication that we are prescribing. So we see that for cephalexin, we can choose from a 125 milligram per 5 ml concentration or a 250 milligram per 5 ml concentration. How do we choose? Well, we look at the amount we have to dispense. If I use the higher concentration, which is 250 milligrams, the patient will need 5 mLs, which is how many teaspoons? 1. 1 teaspoon 3 times per day. If I had used the 125 milligrams per 5 ml concentration, my patient would have to take not 1, but 2 teaspoons of the medication 3 times per day in order to get the same amount in his system. Ultimately, you have to look at the calculated dose in milligrams in order to determine the best concentration. If the child was a lot smaller with a lower weight, it might make more sense to use the lower concentration, but in this case, the 250 milligram per teaspoon concentration is the way to go. This slide just shows the math over on the left-hand side. On the right-hand side, you see the actual prescription. You can see that we have the drug name and on the same line the concentration of the drug that you want the pharmacist to use, which is 250 milligrams per 5 ml. SUSP stands for suspension. Many people often skip down to the SIG next and write 5 mLs, or you could also write 1 teaspoon, by mouth 3 times daily for 7 days. Then, based on those instructions, you can calculate the total amount to dispense. 5 mLs times 3 equals 15 mLs per day times 7 days, which equals 105 mLs. Your dispense amount will need to be in mLs because that is how the concentration is written, so you need to stay consistent for the pharmacist. In this class, I don't want you to dispense more than the calculated amount. We often do that in real practice to account for spillage or spittage, but in this class, I want you to put the exact amount you want dispensed based on your calculations, so I know that you understand how to obtain that number. And don't forget the refill amount. This patient will only be taking cephalexin for a short course for his impetigo, so we'd indicate no refills and then sign the prescription. Once again, here is a list of all the required components on a prescription. Don't forget to include the patient's weight somewhere on the front of the prescription near his or her name if you're writing for a weight-based medication. And my parting words to you are some recommendations to cover your donkey. Always keep your prescription pads in a locked location and minimize the number of available prescriptions you have in use at any one time. Patients are not the only ones that may try to forge prescriptions. Sometimes your very own nursing staff or administrative staff members may see a blank prescription laying around as an opportunity. Remember to write out the actual amount prescribed. Never pre-sign or predate your prescriptions and use tamper-resistant prescriptions which include watermarks, which are now a federal requirement. Consider prescription pads like a checkbook. You wouldn't sign a bunch of blank checks and leave them out for anyone to grab and fill in an amount of their choosing. So be cognizant of your prescription writing etiquette and be meticulous in what you write for each patient. We will put all of the concepts presented in this recording into action during our prescription writing workshop. Be sure to bring a pen, a calculator, and your newfound prescription knowledge to that workshop. It'll be fun. See you then.